الله يصبحكم بالخير. بده نبدأ اليوم بالدكتور علي الدغمين, the clinical director of the urology department, urologic oncology, laparoscopic and robotic surgery consultant, kidney transplant surgeon, العبدلي Medical Center at Jordan Hospital, on the expanding role of partial nephrectomy. تفضل دكتور علي.
Thank you. صباح الخير حابين نشكركم صراحة على التنظيم الرائع الصراحة وموفقين إن شاء الله. First of all, I have two parts in my presentation. First part will be a PowerPoint presentation about the role of partial nephrectomy, expanding role, but I have to go through it very quickly. It's like more 70 slides. To go to the second part of my presentation will be about a couple of videos about complex renal masses. So renal cell carcinoma remain one of the most commonly diagnosed genitourinary malignancies. In Jordan, like kidney cancer, the 10th most common cause of cancer in all Jordanian males. I don't need to go through staging. Radical nephrectomy has been the gold standard for management of kidney tumor. In the past, whatever the size, just go for nephrectomy. Then a lot of studies challenge this type of practice, and some studies reveal the benefit of partial nephrectomy versus radical nephrectomies. But the questions has been raised against radical nephrectomy for small renal masses because this carries possible over-treatment, also significant proportion of tumors, especially when the tumor is less than 4 centimeters, you have a significant number of benign masses rather than cancer. Also, there is a role for chronic kidney disease resulting or surgically induced chronic kidney disease from radical nephrectomy. In the past couple of years, diagnosis of small renal masses has increased due to use of diagnostic tools and imaging tools for other reasons. So we have a trend toward diagnosing renal masses at a smaller size than in the past. So the idea behind going for partial nephrectomy rather than radical nephrectomy is the role of it preserving renal function, lower risk of cardiovascular disease, better overall survival, and equal cancer control. So with this, treatment paradigm has been changed for the last decade toward more partial nephrectomy for small renal masses. And this is like a study, one of the studies that demonstrated the chronic kidney disease per se, whether this is induced surgically or medical chronic kidney disease, it increased risk of death at increased risk of cardiovascular events. This is the similar study that revealed even radical nephrectomy for small renal masses can induce increased risk of cardiovascular disease and chronic kidney disease. I will go through this slides. This is the third point, that if you have a new technique for management of renal masses, this technique should offer and provide equal cancer control. This one of the earliest study that demonstrated partial nephrectomy for small renal masses T1A 4 centimeter or less, it provides equal cancer control to radical nephrectomy. Then with time, the role of partial nephrectomy has expanded to include more tumors like T1B 4 to 7 centimeter and T2 tumor. And still we have cancer control similar to between radical nephrectomy and partial nephrectomy. And this is also the expanding role. This is another meta-analysis demonstrated similar cancer control between both radical nephrectomy and partial nephrectomy. This is very important subject. Over years, even in the Western countries, the utilization of partial nephrectomy for small renal masses is underutilized. And this underutilization is more prominent in community hospital rather than university hospital and oncology centers. And this is one of the earliest studies. If you see, this is from Memorial Sloan Kettering Cancer Center, and you can see the trend between years to use of partial nephrectomy and partial nephrectomy for small renal masses, and radical nephrectomy decreasing and using for small renal masses. Similarly, this is the trend for bigger tumor, for T1B tumor. If you see, similarly, over years, there has been increasing use of partial nephrectomy compared to radical nephrectomy. This is my study. I have done it in 2017 at KHCC, and we studied the trend of using partial nephrectomy at Jordan, or KHCC specifically. And if you see here, over years, there's been some increase in use of partial nephrectomy. And 2015, we reached more partial nephrectomy than radical nephrectomy. And this is between years, like between 2016, 17, and 2010. This is partial, and this is radical. Then we further analyzed the use of partial nephrectomy for T1A. And if you look here, more than 90% of patients with T1 disease had partial nephrectomy rather than radical nephrectomy. And this is the approach. 93% of the patient had laparoscopic approach rather than open approach. This is for T1A disease. For T1B disease, 85% had partial nephrectomy. Only 15% had radical nephrectomy. And for T1B, the number decreased to 80%, and 19% had radical nephrectomy. This is the approach. 75% had laparoscopic approach, 25% had open approach, and for T2A, the number of partial is like around 60, and 40% had radical nephrectomy. This is a very early laparoscopic studies demonstrated I think this is from three big university hospital at USA, and if you see around 700 patients under laparoscopic, 700 patients underwent open approach. And this is if you look at the average ischemia time, which is closer to the artery or the vein during the surgery, it's a kind of long, 30 minutes, 20 minutes. This slide, I'm presenting it because the next slide I'll present my data regarding the partial nephrectomy. So nephrometry score here, if you look, which is a measure or a tool to measure the difficulty of doing the surgery. And if you look, I divided the nephrometry score between less than 7 and more than 7. 7 means intermediate to high risk procedure. And if you see most of the patients or more toward a high risk procedure than rather than a low nephrometry score. And if you look here at average blood loss, we have in open surgery 500 cc and laparoscopic 240 cc. And the length of hospital stay 5 days compared to 3 days. Adverse event, we had 4 patients developed urinary leak, 2 had partial, 2 of them were T1B, and this is expected because the urinary leak is more with patients who underwent partial for bigger tumor. So I'm gonna stop right here. I'm going to show you some complex partial effect. Videos, please. Okay, this is totally back with the video, please. This is a very complex, we call it endophytic tumor. If you look at the CT scan here, here's the tumor, just at the center of the kidney. And we've done for this patient laparoscopic partial nephrectomy. As you know, first we mobilize the bowel. Move the video, please, a little bit. And this is to control the artery and the vein. And this is, I think, this patient had 2 arteries also. Move, please. And then we expose the kidney to see the expected size of the tumor. Move a little bit, please. And this is we control the artery and the vein before going to resect the tumor. Move a little bit, please. And this is the tumor, very nicely encapsulated tumor here. With this kind of, this is the renal pelvis. I open the renal pelvis and collecting system because the tumor is sitting on the collecting system. Because this is endophytic tumor, you have to remove all the kidney tissue above the tumor. That's why we have like a little bit increase in the resection of the normal kidney tissue around the tumor. Move a little bit, please. This is the collecting. Then in my technique, I do early unclamping technique, which is just I close the first layer, then I open the artery and the vein. I think in this case, I did the ischemia time was around 22 minutes. No bleeding here because the artery and the vein is still closed. Move a little bit, please. Just I will show you after removing the clamps. Move a little bit, please, to see the end of the. This is at this stage we remove the clamp from the veins and from the artery, and you see no more bleeding. At this stage, usually I put some material just to prevent the bleeding, Surgicel, sometimes Fibrillar, and then I close with the second layer. Next video, please. Next video, please. This is same video. And this is kind of, I think T2A tumor or T2B tumor, very large tumor. Can you start from the beginning with the video, please, to see the CT scan for the patient? Yes. First, from the beginning. This is very large here, kidney tumor. I think 11 or 12 centimeter, taking most of the kidney. This is a Bahraini patient. I guess if I can remember, the pathology was oncocytoma for this case. ليزر مش شغال لو سمحت. ليزر.
مفيش بوينت.
ليزر مش شغال، بحاول اعمل بوينت الشرح. شكله بطارية. Move the video, please. And move more, please, just to finish. More. Move, please, more. More. Move, please, more. That will very long. At this stage, we expose the kidney to see the margin of the tumor. More, please, move. This is the resection of the tumor. Very huge tumor, this one. So even when you close the, sometimes I don't close the vein, so sometimes you have some ooze from the bed of the kidney. With this kind of big tumor, I used to open the collecting system just to make sure I'm below the tumor to avoid doing positive margins. Move, please, move. This is at the end of resection. Move, please. Similarly, I close one layer, then I open the artery and the vein, then I'll finish with the second layer of clamp, second layer closure. Move, please, to second video, please, second video, just to show you as maximum as we can from the videos. This is a hilar tumor just sitting on the artery and the vein. Move, please. At this area, usually I do maximum dissection and separation of the artery and the vein from the tumor while not using the clamp to minimize the ischemia time. This is the one here is the vein, so I'm removing the tumor from the surface of the vein. Move a little bit, please. Regarding energy device, sometimes I use ligature, sometimes I use harmonic. For this kind of fine dissection, I prefer the harmonic because the tip is like a kind of sharp. This will help you during dissection. This is here the artery and the vein and the tumor just above both of them. Move the video, please. Move, please. This is the clamping. Okay, he moved the resection and all. Okay, next video, please. And this is very interesting case. This lady is, I think, 22. She was discovered, stop please at this stage. She was discovered to have, this is a huge angiomyolipoma during her late pregnancy. So, back to the previous video. So she was diagnosed with this huge angiomyolipoma. She completed her pregnancy. After 6 months, she went to the radiologist. He could not embolize this huge angiomyolipoma. What I did for her, partial nephrectomy for this huge angiomyolipoma, in addition to another 4 tumors in the same kidney and 5 tumors in the other right kidney, very small tumors, in one sitting. This is another hilar tumor. This kind of very difficult tumor, posterior hilar. The approach for this kind of tumor sometimes is difficult. So this is the ureter here coming inside very close to the kidney, to the tumor. I don't have pointer, I'll show you. This is the ureter down. Usually when I do hilar tumor, I do close both the artery and the vein to minimize or to maximize the visualization. Ischemia time 20, okay. Thank you. Next video, do you have more videos? I think we have seen this one. Next video, please. We've seen all the videos. Okay, thank you. Thank you. All good. Thank you. Any question?
بجوز لبعد
Okay.
السيشنز كلهم
شكرا.
نعمل
شكرا.
all the questions together.
يعطيك العافية.
And now we are pleased to hear Dr. Walid الزعبي, who's a consultant anesthetist and a chair of anesthesia department at Jordan Hospital. He has special experience in liver transplantation, bariatric surgery, and maternity anesthesia, as well as pain control clinic. Reperfusion injury continues to be a challenging phenomena in the surgical practice, and in the interventional practice. We're going to hear about post-reperfusion syndrome in liver transplant surgery in the private sector. تفضل دكتور وليد.
تعالى كمان. خلاص mic on. Good, thank you. I have a pointer. Say it again. ما هي واحد. ما هي واحد. ما هي ليزر. Okay, next slide من عندنا ولا من عندي هون؟ Yeah, absolutely. Now, good morning all. It's a pleasure to be among you and to share with you our humble experience in liver transplant. To start with liver transplant, for people who haven't done liver transplant surgery, whether from the surgical part or the anesthetic part, we consider with proof that it is one of the most challenging, difficult, and at the same time advanced surgeries ever. And we hope that we get more collaboration with you. I know that some of Palestinian origin patients get to us to do liver transplant. We have a special experience in living donors. The way we did it before, or we trained before, is to do cadaveric ones. Still, the donor is more challenging because you have double responsibility, I would say, on two patients where we can't get anything wrong with the donor, and that just increased the pressure on us all time. One of the most difficult times during the surgery is the reperfusion. It is the time where surgeons liaise with us all time in minutes and seconds to tell us that they're going to reperfuse the graft when the portal vein is opened after a relatively good or bad ischemia time. And that's when people go down. I'm talking about patients, or they tend to go down in their blood pressure. So it's mainly about blood pressure. And this dictates the survival, the outcome, the complication rate, the survival rate, et cetera, of those patients. And that's why it is important, and there is no joke with getting a hypotensive patients for a certain time after receiving his new liver. This is the place where I came from, Jordan Hospital, working as a chair, as was introduced a minute ago, of anesthetic department. And it's a pleasure to be part of this place and to have me here as an institution, as a person as well. So thank you. This is just a brief of what we are in Jordan Hospital. We're affiliated with some American hospitals like George Washington and Toledo, and have got a lot of accreditation in the past, and this is where I personally learned what I'm talking about today in Ireland and UK. To define post-perfusion syndrome, it's exactly as is on the slide, a decrease in the mean arterial pressure greater than 30% below the baseline, lasting for at least 1 minute. So we expect the blood pressure to go down for so many reasons, but more than 1 minute, we consider it a syndrome. And that, as I said a minute earlier, it is a factor that dictates the outcome and the survival of the graft and the patient as well, which occurs in the first 5 minutes after reperfusion of the liver graft and clamping of the hepatic hilum. And I'm sure Dr. Jihad would remember his more than 50 cases that he did in Jordan Hospital in good times, I would say, before he left us. And you're winning him. We are the losers to have him back here. a lot of research was done on this. Hilmi et al. And his colleagues later expanded the classification into mild and significant, where the mild would be just with the heart rate not reaching 30% of the baseline, lasting for less than 5 minutes, and responsive to intravenous bolus dose of calcium chloride, epinephrine less than 100 mic, without the need of continuous infusion of vasopressors. So we treat this mild reperfusion syndrome with boluses as we go. The significant one is the one that lasts more than 5 minutes, with more than 30% drop in mean arterial blood pressure, and the need for continuous vasopressors on board. Other presentations of significant perfusion syndrome include a prolonged more than 30-minute or recurrent. So it's all classifications trying to get you to the idea that hypotension is serious in this situation. It is divided into phases, where phase 1 is or starts from the perfusion of or the opening of the portal vein to 5 minutes after the portal vein perfusion. And that's why in theater you usually hear my voice saying 1 minute lapse, 3 minute lapse, 5 minute lapse. And they have to know what I'm talking about, which gives them the power or the need to hurry up and do something when we are going hypotensive. Vasopressors and volume rolling are often used to manage hemodynamics in this phase. Phase 2 starts after the 5 minutes after portal vein reperfusion and characterized by a progressive decline in the mean arterial blood pressure until the hepatic artery perfusion is completed. Phase 3 from the hepatic artery until 240 minutes after the portal vein. So we stay on our toes, as they say, till 4 hours after the surgery. It is a relatively common. We see it quite often, and we don't get surprised. We get ready to treat hypotension starting from our ears without even looking at the monitor. Personally, and it's not only me, a lot of experts in this area or field start treating according to the heart rate. Once we hear that the patient has got a bit of tachycardia, this means that he is going down, or at least his blood pressure is going down, and we start giving epinephrine before we see the blood pressure numbers going down. Now, post-operative acute kidney injury, early graft dysfunction or rejection, reduced graft and patient survival are all related to PRS. This is just in simple English to show you how serious this is. It is a severe complication during the surgery following the portal vein declamping and associated with hostile metabolic and cardiovascular disturbances that can affect the mortality and the survival of the patient. Well, as you can see, it's quite simple. Nobody can put one finger on what happens when we open the portal vein. It's quite complicated. Regardless of this, we need to treat it. There is no place for thinking of why is that happening. You heard me saying 5 minutes. Those 5 minutes are quite serious. And although the definite mechanism, as I said, of the syndrome is complex and not fully understood, the good news, it is attributed to the release of oxygen-free radicals, endotoxins, inflammatory cytotoxins, such as tumor TNF, and interleukins, vasoactive hyperkalemic cold acidotic substance in the graft. And this is why the longer the surgeons wait on the graft before they get it in, the more severe and complicated our life is later dealing with this syndrome. There are risk factors, and they are quite studied in a very good way and clear enough. They reviewed retrospectively and involved single transplant centers using different anesthesia protocols. Hence, it is hard to draw a decisive picture of the most important one of them. They're all known, but we can't really point that this is more important than this. From the risk factors, and that is published quite recently in April 2022, age of more than 60 years, I'm talking about the recipient, because we don't take from people above 60 years, and there are rules on that from the Ministry of Health and all that. It's quite regulated. Child class C, higher model end-stage renal failure, liver failure, pre-operative sodium of less than 130, parameters of the liver recipient, increased the cold ischemia time, that is a donor parameter, and the classical technique. The surgical parameters were the strong predictors of PRS, whether it's a piggy clamp or complete clamp of the portal vein or the inferior vena cava, and indicated that the underlying liver disease was not the predictor of PRS in the presence of other risk factors. Factors associated, again from Anesthesia Analgesia 2022, results concluding in the liver donor liver transplant, a male sex is more prone to have the perfusion syndrome, the presence of a small left ventricular and diastolic diameter in the recipient, large graft volume, more toxins, more interleukins, more TNF will be released. Our problem that the liver is toxic. When it's taken from the donor and given to the recipient, it has a lot of toxins, and we have to deal with that. Lung and hepatic time are associated with the syndrome more. This is something related to the recipient as well. And a high calcium ion concentration with low pulmonary artery pressure before reperfusion are negatively associated. And this is why we have to monitor those guys quite closely during theater. What we do, and I do personally, is we put 2 arterial lines so that when we need, and we always need, to draw a sample, whether it's an ABG, a gas, or calcium, or hemoglobin, no one touches my arterial line. So I have an arterial line that is working all time without any without any disturbance, and I have another arterial line to do all the sampling and all that. And at the same time, talking about 2 arterial lines, we have 2 central lines when we do that. We have a VAS cath or a dialysis cath, not for the dialysis, well, sometimes we need, if there is an acute kidney injury, rarely speaking we need that, but we have this just to give volumes in the way we like. When we say give fluids, we use the pressurized machines to get the fluids in, and that needs a very wide bore central line. Again, MELD score, age, high creatinine, high potassium, low calcium level and low hemoglobin level, ventricular diastolic dysfunction preoperatively, and sometimes we have to put the patient down if they have a weak diastolic function or say a high pulmonary pressure. And the answer for this, and I'm sure there is, and there will be never a randomized study to tell how patients do if we get them with high pulmonary pressure and how they do when they don't. We can't compare those, but we put it in simple English that people with high pulmonary pressure, and it happened with myself when the echo was done in the last few days, we had to cancel surgeries because simply they don't do well. And that is our answer. There is no definite number for that, but because they don't do well, we cancel their big surgery. Others have correlated it with elevated heart rate and low CVP and fulminant hepatic failure. The hemodynamic response of to clamping of the IVC is also correlated, and that's what I was talking about when the surgeons do a piggy clamp, which is a partial clamping of the IVC or not. And we do sometimes intraoperative testing to see how things would go, just to try it, because it will take us 1 minute to know how would patient go. The syndrome occurs more frequently in patients who do not react with substantial increase in systemic vascular resistance index after the clamping of the inferior vena cava, showing weaker cardiovascular reflexes. Mechanisms, The genesis involves multiple systems, global hemodynamic aspects from ventricular arterial decoupling, right cardiac function and pulmonary circulation, still a matter of debate, cirrhotic cardiomyopathy, something that we had to deal with from preoperatively, the hyperdynamic circulation, a typical feature of advanced cirrhosis, and its severity is often reflected by the mild score and the child score. Intestinal ischemia reperfusion injury. Bad perfusion, disrupted intestinal barrier will correlate in a negative way to the syndrome. Ischemia time, again called ischemia time of the liver, is the most frequently appointed, where we can say that at the long ischemia time, we're going to have the patient blood pressure down to our feet at some stage, and we get ready for that. Procedure-related factor, preservation solutions, the washout time and technique. Prevention and management. To this date, the treatment of this is supportive. So we go with the flow. We listen, we see, and we act. There is no perfect recipe for this, unfortunately. There is no holy book. I've done this in so many centers. Every center has its own protocols. However, the severity of the syndrome can vary greatly, and so the efficacy of the treatment. A number of strategies to prevent the occurrence and reduce the hemodynamic effect have been proposed and could improve outcomes. Yet, to this date, none of them are strongly supported by evidence. As I told you, it is a very critical time, and we can't try to do this and that on patients to see whether this treatment is okay or not. Well, to start with, we might lose patients. And if we want to do a research on this, back to square one, we need to get a consent of a patient. And that is nearly impossible, and I would say unethical. And however, despite the improvement of surgical and anesthetic techniques, the effective treatment is lacking. There are some people talking about ischemic preconditioning of the transplanted graft. Heart surgery was the first one where they tried to do that, applying brief period of ischemia, that's the concept, and reperfusion to the tissue before more prolonged ischemia time. So trying that outside and then doing it inside. In liver surgery, it's widely applied to warm ischemia in liver resections. The outcome and mechanism by Xinyan is still there, but they're talking about positive results with no strong evidence. It plays an essential role in hepatectomy before and after harvesting the liver donor and implantation of the graft. Ischemic preconditioning delivered by K.S. Gursami concluded that there is currently no evidence. So some people say it's essential, and other people say it is fruitless. It has no evidence to support or refute at the same time the use of ischemic preconditioning. Further studies, that's what they concluded, is needed are needed to identify the optimal ischemia preconditioning. Further randomized clinical trials are necessary, and that is what I'm talking about. Randomization of those patients is not an easy thing to play or fiddle with. In conclusion, the syndrome has been widely investigated in both physiological and risk factors, but the level of evidence that can be drawn from the analysis is still poor, at the very least word I can say. The presence of two main definitions of the syndrome complicates the interpretation, the results of the study considered. So there are, and people who defined it are like well prestigious people. You're talking about UK, you're talking about Ireland, you're talking about Australia, you're talking about America. None of them agreed globally on one definition. Since the complexity of the phenomena is high, future studies evaluating the risk factors and therapeutic strategies should pay more attention in granting possible standards of management based on adequate evidence. And thank you.
Okay, thank you, Dr. Walid.
Thank you.
غدير. 20 minutes.
بدي أقدم الدكتورة غدير عابدين who is going to speak about risk factors of breast cancer. Dr. Abdeen is a consultant medical oncologist and the chairman of the scientific committee at the Jordan Hematology Society. She works at King Hussein Cancer Center, and she's an expert in breast and gynecology oncology.
Thank you, Dr. Chairman, for this nice introduction. And I would like to thank the organizing committee for inviting us, actually for making the dream to visit Khaleil. The level of conference is highly organized. The lectures, the speakers are extraordinary. Shukran, Dr. Jihad, Dr. Ahmad, Dr. Abdul Karim, and Dr. Omar for this nice introduction. And I would like to start my lecture. Okay, we'll talk about epidemiology and risk factors of breast cancer. Mainly, I try to have certain statistics about Jordan. Globally, as you know, breast cancer is the most common, constituting around 23% of all cancers diagnosed all over globally. 14% of all cancers death is due to breast cancer. And globally, again, breast cancer constitute around 20%. It's the most common globally, followed by lung, colon, uterine, thyroid, melanoma of the skin, non-Hodgkin lymphoma, renal, ovary, and pancreas. And remember, the probability of breast cancer, 1 in every 8 women will develop breast cancer. It's not uncommon, it's very common, the most common cancer. In every كل من بين 8 ستات 6 وحدة سوف تصاب خلال المرحلة العمرية with breast cancer. What about the statistics? The statistics actually comes from the Jordan Cancer Registry that is updated every 5 to 6 years. In 2017, we have the total cases of cancers 8,152. Jordanian كانوا حوالي 6,000. Non-Jordanian حوالي 2,153. There is a trend of increase if you see the cancer. There is increase in the pointer شكله ما بيشتغل. Okay, as you see, there is increase in the risk of or the cancer incidence in Jordan, and we have 2 causes for this: better cancer registry and the screening program, especially the National Breast Cancer Screening Program. They are doing a great job. They have a mobile unit that can access the not only عمان بمادبة بإربد بالسلط بالجنوب بالشمال. They have mobile bus بيكون في mammogram unit that can access and do screening mammogram. This is also showing you how there is increase in both males and females due to better cancer screening, better cancer registry. We know that age is the most important risk factor. So بتشوفوا معظم الحالات بتكون between the age of 60 to 70. مرات بيحكوا انه in Jordan the incidence is higher than others. Actually, I tried to find the Palestine incidence. I could not find. لكن احنا in Jordan I think عندنا هون بفلسطين اكيد الامور رح تكون نفس الشيء. احنا مش اكثر من غيرنا 138 per 100,000 population. لبنان اكثر منا، الكويت اكثر منا بشوي، عمان اقل منا، وباقي الدول طبعا اكثر، بس لبنان هي actually اكثر منا بعدد الحالات. According to the National Breast Cancer Registry, breast cancer even لما يعدوا بين males و females بضل breast cancer is the most common بشكل حوالي 20%, followed by colorectal, lymphoma, trachea, thyroid, bladder, prostate, leukemia, and stomach. Among males, the most common is colorectal, followed by lung, prostate, bladder, and non-Hodgkin lymphoma, leukemia, lung, kidney, CNS, and Hodgkin disease. Among females, we diagnosed yearly حوالي 1000 و 3000 حالة in new cancer breast cancer patients constituting around 39%، يعني 40% أو 39% من الحالات in females is due to breast cancer. معظم شغل الأونكولوجي in KHCC and outside KHCC يعني 40% بيشتغلوا على breast cancer. لما برضه الريجستري على non-Jordanian also breast is the most common 44% followed by colorectal, thyroid, uterine, lymphoma. Mortality, the most common mortality is from the lung followed by breast, unknown primary, colon, leukemia, pancreas and non-Hodgkin lymphoma. This is in 2017. What about the stages? حوالي ثلث الحالات بيجوا localized، 45% بيكونوا regional يعني metastasis to the lymph node، 10% بيكونوا distant metastasis. What are the risk factors؟ شو الأشياء اللي بتزيد من نسبة الإصابة بسرطان الثدي؟ الage، الريس، benign breast tissue diseases، personal history، lifestyle، reproductive, hormonal factors، environmental factors, radiation and smoking. 50% of breast cancer can be explained by risk factors. 10% عادة من الحالات بيكونوا associated with positive family history، مش أكتر من هيك. Age is the most important risk factor. As you see احنا بس بالأردن صراحة الحالات بتكون أصغر than the international data. حوالي 43% من الحالات between the age of 20 to 50. 36, 1/3 of the patient is more than 50 years of age. Benign breast tissues has increased the risk of breast cancer, but not simple fibroadenoma. يعني simple fibroadenoma, fibrocystic disease, solitary papilloma does not increase any risk of breast cancer. Benign breast tissue that should be removed surgically that increase the risk of breast cancer are complex fibroadenoma, sclerosing adenosis, intraductal papilloma, atypical ductal hyperplasia, and atypical lobular hyperplasia with different relative risk increase in the incidence or the probability of developing a breast cancer. طبعا البيرسونال هيستوري اللي عنده بيرسونال هيستوري اوف ان سايتو ديزيز بيكون نسبة الكونترالاترال breast is increased by 5%. The invasive breast cancer, if the patient is a breast cancer survivor, she has the risk to develop another primary in the contralateral breast around 0.5 to 1% in postmenopausal versus premenopausal. The most important diet that is associated with breast cancer is alcohol intake. So they are doing many studies showing the more that people drink, the more they got breast cancer. The fat intake, there is no evidence between association between total dietary fat intake and the risk of breast cancer. Even when they do reduction, this does not result in lower risk of breast cancer. The role of calcium, vitamin D in postmenopausal, the intake of dairy product, calcium and vitamin D in postmenopausal lady does not increase the risk of breast cancer. The contrary in the premenopausal lady, high consumption of low-fat milk, daily calcium more than 800, vitamin D more than 500 international unit have lower risk of breast cancer. Postmenopausal breast cancer risk was decreased when you have a level 12% lower level or higher level of increase in the vitamin D between 27 to 35 in the the serum vitamin D blood level. More than 35 there is no reduction. There is no association between 25 hydroxy vitamin D level and breast cancer risk in premenopausal women. This is only in postmenopausal. Phytoestrogen هذا اللي بيكون موجود بالايزوفلافون، اللوجومز، الصويا بينز ومشتقات الصويا بينز has been associated with breast cancer. موجود بالسيليارز، بالفيجيتابلز، بالفروتس and it has been associated with if you intake high intake more the 20 gram per day, there is 30% reduction in the risk of breast cancer. High intake of the soya bean containing meaning which is the Asian type of food. So it is associated with lower risk of breast cancer. The antioxidant اللي بنعرفهم vitamin E, vitamin C has no relation to breast cancer risk, and there is conflicting results about vitamin A. Mediterranean diets, our Mediterranean diet actually, to the contrary, the extra virgin olive oil, when you have nuts, there is lower risk of breast cancer. This is studied by meta-analysis and multiple studies. So our Mediterranean diet supplemented with extra virgin olive oil, especially أكيد من الخليل, بيكون has lower risk of breast cancer. كافيين دبس أكيد. القهوة ما إلها علاقة, there is no association. reproductive factor, طبعا السيدة كل ما تعرضت لاستروجين ليفل في حياتها بتكون معرضة أكثر للإصابة بسرطان الثدي. So prolonged exposure and higher concentration of endogenous الموجود بالاستروجين. حتى post menopausal, بعد المينوبوز main source of estrogen بيكون بالاديبوز tissue, بتحول الدايهيدروكسي epandrosterone derone from adrenal gland converted to the estrogen. So in premenopausal we have estrogen, and after, but of course it's at higher level, and after menopause it's converted in the adipose tissue. What are the reproductive risk factors that is associated with age of menarche, age of first live birth, age of menopause, parity, and breast feeding? Every 2-year delay in the onset of menarche has 10% reduction in cancer risk. كل بس البنت الايج اوف مناركي كان اطول او ابعد بقلل الريسك، لانه بيكون كميه الاستروجين اللي معرضت له اقل. الليت مينوبوز كل ما صار ليت مينوبوز each year delay at all order menopause has 1% relative reduction in cancer risk. مرات لما يعملوا bilateral oophorectomy it decreases the lifetime risk by 50%. بقلل نسبة البريست كانسر. طبعا ما بننصح احنا الناس يعملوا اوفريكتومي مشان يقللوا except اذا كان عندهم جين البراكا 1 وبراكا 2 جينز. اللي المينوبوز لما يكون المينوبوز at age of يعني early menarche late menopause بتزيد نسبة الإصابة بسرطان الثدي early menarche and late menopause. الناليبيرس اللي ما بتخلف بتكون at increased risk of breast cancer. The protective effect of a pregnancy is not seen until after 10 years after delivery, but in nulliparous has higher risk of breast cancer. Okay. The pregnancy history اللي بتجيب على عمر صغير بتكون lower incidence، يعني 10% lower إذا كان pregnancy at age of 25. إذا كان higher إذا كان أكثر من at age 35 and above بتكون percentage أعلى. Risk is same for nulliparous and first birth at age of 50. طبعا كل ما الست خلفت في سن أبكر بتكون محمية أكثر. البريست فيدنج كتير important. Every 12 months breastfeeding بيقلل نسبة الإصابة بحوالي 4%. الابورشن ما له علاقة بالبريست كانسر. البوست مينوبوز ladies as طبعا every 10 kilogram since menopause increase the risk by around 18%. If you lose 10 kg the risk will be lower. بس هذا الحكي بالبوست مينوبوزال. بالبري مينوبوزال ليدي على العكس ما عرفنا السبب. بالبري مينوبوزال بيكون an increase in body mass index is associated with lower risk of breast cancer in premenopausal women. الهايت طبعا ما بنعرف السبب. الطوال وهذا طبعا ما حدا بإيده is more likely to develop a breast cancer. What about physical activity? Physical activity is very important for many types of cancers, for heart disease, to lose weight. So brisk walking حوالي ساعة لساعتين per week is associated with 18% risk reduction of breast cancer. physical activity لأنه بتقلل السيرم استروجين، الانسولين والانسولين growth factor. هلا السموكينج وعلاقتها بالبريست كانسر مش أكيد زي اللنج زي البلادر but still there are studies showing higher risk of breast cancer. estrogen level higher level of endogenous estrogen level زي ما حكينا بيزيد نسبة الإصابة بالهرمون ريسبتور بوزيتيف بريست كانسر. في عنا أنواع كثيرة من البريست كانسر من ضمنهم هرمون ريسبتور بوزيتيف، مشان هيك بنعطيهم aromatase inhibitor suppress ovarian function مشان يخففوا الريسك of breast cancer. Testosterone has been associated with increased incidence of postmenopausal breast cancer. البون density اللي عنده كثافة العظم شديدة عند الفيميلز لقوا إنهم higher incidence of breast cancer by around 60% versus lowest bone mineral density اللي بنقيسه بصورة الدكسا سكان. الانسولين growth factor is associated with higher risk of breast cancer in pre and postmenopausal. Diabetes per se is an independent significant breast cancer risk. يعني diabetes per se برضه بيزيد الإصابة بسرطان الثدي. breast density لما نعمل ماموجرام ونشوف البريست دنس بيكون مور طبعا لانه بصير الديتكشن اوف بريست كانسر اصعب لما يكون الماموجرام دنس، مشان هيك the risk might be higher. البوست مينوبوزال هرمونال ثيرابي للاسف يعني احنا يعني بعض الأطباء بيستخدموا البوست مونوبوزال هرمونال ثيرابي كحبوب مشان يحاولوا يخففوا على المرضى البوست مينوبوز الهوت فلاشز، وبرضه بيفكروا إنه هذا بيحمي من الكارديوفاسكولار ديزيز. actually في ترايل كبيرة اسمها Women Health Initiative Trial. هاي study كتير كبيرة هدفها يشوفوا to investigate the strategies of prevention and control of the most common causes of mortality and morbidity among postmenopausal women. درسوا الكانسر، درسوا الكارديوفاسكولار ديزيز، درسوا الاوستيوبوروتيك فراكتشر. حوالي 166 ألف سيدة in the US أعطوهم conjugated estrogen مع ميثروكسيبروجسترون versus placebo، ولقوا زي ما شايفين بالخط كيف الهرمون ريبليسمنت ثيرابي بيزيد نسبة الانفيزيف بريست كانسر، وطلعوا على الجراف كيف still increasing يعني عم بتزيد الحالات كل ما أخذوا الهرمون ريبليسمنت ثيرابي اللي بعطوها after menopause. لقوا إنه في decrease incidence of colon cancer، decrease hip fracture، بس حتى لو صار عندها الست breast cancer the mortality rate from breast cancer is higher. So what is the recommendation regarding hormone replacement therapy? Long-term use is associated with higher incidence of breast cancer and is not recommended. If you want to use it, just use it short-term for less than 3 years, but make sure or remember that this will make the mammogram more dense and you cannot detect early breast cancer. But still, it might be recommended to decrease the incidence of vasomotor flashes, but I think now we have many herbal issues. We have for example, I give my patients vitamin E to decrease the incidence of hot flushes. No longer recommended the prevention of coronary heart disease and osteoporosis. حتى لما تطلع على الليبل تبع الهرمونات بتلاقوا ال FDA حطت warning label إنه this product increase the risk of stroke, heart disease and cancer. Fertility drugs does not increase the incidence of breast cancer in women اللي بيستخدموه for the IVF. الفاميلي هيستوري طبعا كل ما كان الإنسان عنده فاميلي هيستوري، إذا كان 1 first degree relative بيزيد الريسك، 2 first degree relative بيزيد ل 3%. إذا كان early breast cancer إذا كان 2 minutes okay. There is طبعا family history كلها بتزيد. genetic mutation اللي بنعرفهم only 5 to 6% بيكونوا related to BRCA1 BRCA2 mutation، وهدول إلهم special طبعا treatment. الionizing radiation اللي بتعرض لها بعض الفيميلز اللي هم أخذوا radiation على منطقة الميدياستاينم بيزيد الريسك of breast cancer. night or nocturnal light exposure بيزيد الريسك اوف breast cancer. واحنا دائما في عندنا issue estimation of breast cancer risk. It's a computerized. بنحط الايج، بنحط الفاميلي هيستوري، المنسترول periods، المينوبوز، البيوبسي، وبنقدر نحسب قديش الريسك to get a breast cancer. accordingly إذا كان الجيل موديل more than 1.7 أو ماخذة prior radiotherapy أو عندها lifetime risk، هاي اللي ما عندها disease عم بحكي، أو عندها prior history of breast cancer، نقدر نعمل لها special screening guidelines، نقدر نعطيها chemo prevention، نقدر نعطيها risk، نعمل لها risk reducing surgery، bilateral mastectomy، risk reducing bilateral salpingo-oophorectomy. My last slide just to try to lifestyle your life by decreasing the use, of course, of postmenopausal hormone therapy, breastfeeding, avoiding weight gain, maintaining a healthy diet. ما في specific diet except alcohol, regular physical exercise, and refraining from alcohol and smoking. And thank you.
Okay, thank you, Doctora. We invite now Dr. Khulud Al-Qasim. Dr. Khulud Al-Qasim is a medical oncologist at King Hussein Cancer Center. She is specialized in gastrointestinal malignancies with special interests in neuroendocrine tumors. Also, she has many peer-reviewed publications in genitourinary malignancies. As well, she is a specialist in medicine, and she's a graduate of the Jordanian University where she got her training in medicine. تفضلي دكتورة خلود.
Thank you for your invitation. Thank you all. It gives me a great pleasure to be part of this well-organized conference. I will give you a brief update about the management of biliary tract cancer. They are rare types of cancers. They have increasing in incidence mainly due to the increased incidence of intrahepatic cholangiocarcinoma. It is well known to have poor prognosis, and the estimated 5-year overall survival is less than 20%. The majority of patients will be ultimately managed with systemic therapy over the course of their disease. They will get advanced stage diagnosis with a very high relapse rate. The latest guidelines, recommendations in the management of this type of tumor, the mainstay of treatment for early or localized type of tumor is surgery with curative intent. This is the current gold standard of resectable disease. But the relapse rate, mainly the distant metastasis, is very high in this type of malignancy. It ranges from 40 to 70%. We have 3 phase 3 trials that explore the role of adjuvanted treatment. The means of adjuvanted treatment, the chemotherapy that you should start your patient after curative resection in order to decrease the risk of distant metastasis or recurrence or local recurrence. We have 2 negative trials for the adjuvanted treatment, PRODIGE 12 trial that tested GEM-OX as adjuvant treatment, gemcitabine and oxaliplatin, and BCAT trial that tested gemcitabine as single agent treatment as adjuvanted treatment. They both showed failure to improve the recurrence-free survival after surgery. BILCAP trial, this is well-controlled phase 3 trial, randomized the trial open label that enrolled patients who underwent radical and macroscopic complete resection for biliary tract cancer with a good performance status ranging from 0 to 1 based on ECOG categorization. All of the patients, and their number was 400, around 450 patients. After resection, they were randomized to receive single agent capecitabine for 6 months versus observation. The enrollment was continued till disease progression for a minimum of 2 years of follow-up. The primary endpoint for this phase 3 trial was overall survival, and also they look at secondary endpoints just as recurrence-free survival, toxicity, and quality of life. Here you can see that the overall survival in the intention to treat population was superior in the group of patients who received 6 months of adjuvant capecitabine, but it was insignificant by p-value. But when you look to the peer protocol population, it was significantly higher in the group of patients who received capecitabine. What about the secondary endpoints, the relapse-free survival? You can see in both population, in the intent to treat population and the peer protocol population, all showed improvement in the recurrence-free survival in the group of patients who received the tested medication, capecitabine, with significant p-value. So in conclusion, adjuvant capecitabine associated with improved overall survival in the group of patients who with resected biliary tract cancer. And the authors suggest that capecitabine should become the standard of care in this setting. Capecitabine treatment produced modest toxicity, so it is well tolerated in the group of patients who received the medication. And the quality of life in this group of patients versus observation was improved. The authors recommend using capecitabine control arm in future adjuvant trials in biliary tract cancer. Although the overall survival primary endpoint was not met in the intention to treat population, the 14.7 month increase in the median overall survival in the group of patients is clinically significant. So the overall survival benefit became significant in a plan sensitivity analysis. We call it peer protocol analysis, after adjusting based on the nodal status, disease grade, and the sex. So we have overall survival benefit and recurrence-free survival benefit. And we have here the 10 years follow-up of this study. After 10 years of follow-up, we see that the improvement in overall survival is sustained in the group of patients who received capecitabine. What about the metastatic disease? More than 50% of patients presented with metastatic disease at initial presentation. The modality, the treatment, the golden treatment for these patients are to give them combination treatment, combo gemcitabine cisplatin. We have also other proved benefit second-line treatment, such as liposomal irinotecan or Folfox. ABC0 trial that established the efficacy of gemcitabine cisplatin for advanced biliary tract cancer. This is a randomized trial, also phase 3 trial, conducted mainly in UK. It randomized around 400 patients in a 1-to-1 ratio to receive gemcitabine, which is the standard of care, versus gemcitabine cisplatin for up to 24 weeks, 6 months. The median overall survival, as you can see here, also was significantly improved in the combination group, 11.7 months versus 8.1 months with significant p-value. Also, we see in this trial improvement in progression-free survival and in response rate. We see more toxicity associated with the combination, such as neutropenia and neuropathic pain, but it was managed, easily managed. What about second-line treatment? We have 2 options here. Folfox, after the patient progressed on the first-line treatment, gem cisplatin, we can give the patient who are in a good shape, good performance status. We have 2 lines here, Folfox or nab-paclitaxel irinotecan with 5-FU. And here you can see that the median progression-free survival was 4 months in the group of patients who received Folfox, 7.1 with irinotecan, liposomal irinotecan. So the data or the outcome is better in the group of patients who received second-line irinotecan. We have now update about the first-line treatment in this type of malignancy. Adding immunotherapy to the combination chemotherapy improved the outcome in the group of patients who were as first-line, treated as first-line. This is a multicentric randomized phase 3 trial of durvalumab, which is a PD-L1 inhibitor, plus gem-cisplatin, compared to gem-cisplatin in biliary tract cancer. Around 700 patients were randomized to receive durvalumab plus combination chemo versus placebo and gem-cisplatin. After completing 6 months of treatment, the group of patients who received durvalumab will continue durvalumab as maintenance versus placebo as maintenance. The primary endpoint was overall survival, and also we looked to many secondary endpoints. This trial was called Topaz 1 trial, and this is the curve that showed the benefit in overall survival in patients who received durvalumab chemo versus chemo placebo. And you can see here that median overall survival improved from 11.5 to 12.8 months with significant p-value and hazard ratio of 0.81. Also, the tumor response rate was superior in the group of patients who received immunochemo versus chemo alone, 26.7 versus 18.7 months. The treatment-related toxicity was also well known for durvalumab. Most of the grade was 3 to 4, but it was managed with low rate of discontinuation. When we are talking about cholangiocarcinoma, you should know that we have many aberrant mutations well known to cholangiocarcinoma, such as BRAF mutation, fibroblast growth factor receptor 1 to 3 fusions and amplifications, and IDH1/2 substitution, more represented in the intrahepatic cholangiocarcinoma versus extrahepatic cholangiocarcinoma. We have also other rare tumor agnostic aberrations, such as NTRK mutation, MSI high or deficient mismatch repair mutations, and also tumor mutation burden, high tumor mutation burden. All of these rare mutations presented in less than 5% of the metastatic cholangiocarcinoma. FIGHT 202 trial, it established the role of pemigatinib in previously treated cholangiocarcinoma who have fibroblast growth factor receptor 2 fusions or rearrangement. Also, we have here 3 categories of patients who received many lines of treatment before, but they have this aberrant mutation, fibroblast growth factor receptor 2 mutation. They randomized these patients into 3 cohorts. Cohort A, they are well known to have fibroblast growth factor receptor 2 fusion or rearrangement. Cohort B, other fibroblast growth factor 2 genetic alterations, and cohort C, no fibroblast growth factor genetic aberrations. They can see here that the cohort A, who have fibroblast growth factor 2 mutations or rearrangement, have good response to pemigatinib. The overall response rate was 37%, and the disease control rate was around 82%, which is a good outcome for heavily treated cholangiocarcinoma, metastatic cholangiocarcinoma patients. Also, infigratinib is another blocker for fibroblast growth factor receptor 2 fusion or rearrangement, and it gives the same result with around 40% overall response rate and disease control rate at 6 months of about 80%. What about IDH1 mutation? We have here CLARIDY trial that also established the role of ivosidenib versus placebo in previously treated cholangiocarcinoma with this specific mutation. This is double-blinded randomized phase 3 trial that randomized patients who have this specific mutation, IDH1, into ivosidenib versus a placebo in a 2-to-1 randomization ratio. And the patients, the group of patients who received placebo, they allowed to cross over on disease progression to the other treatment group. The primary endpoint was progression-free survival by blinded independent central review committee. Here you can see the outcome. The median overall, the median progression-free survival was 2.7 versus 1.4. And you can see here that the overall survival for a placebo after adjustment for crossover was 5.1 months. So the median overall survival was superior in the group of patients who received ivosidenib. The toxicity profile for this, it's easily managed with low rate of discontinuation rate, mainly fatigue, diarrhea, and nausea. We have also rare mutations, as I mentioned before, in cholangiocarcinoma, can be detected by using next-generation sequencing in cholangiocarcinoma, such as BRAF V600E mutation. In this type of mutation, you can give doublet dabrafenib and tramitinib, and also the overall response rate will be 47%. Also, we have HER2 positive mutation, which is well known in all solid tumors, especially cholangiocarcinoma. It could be detected in about 5% of patients, and you can give him HER2 autoantibodies against this tumor. Mainly, we have trastuzumab deruxtecan. I will not go through this because it's very complicated review. I will go to conclusion. Potentially actionable mutations, molecular alteration are identified in around 30% of biliary tract cancer, including 39% for intrahepatic biliary tract cancer. Molecular profiling should be considered for all biliary tract cancer patients who may stand to benefit from the discovery of potentially actionable mutations. The most important ones are fibroblast growth factor receptor 2, fusion or rearrangement, IDH1 mutations, HER2-neu. They are very important actionable targets for biliary tract cancer. يعني أنا بس ملخصها إنه every patient who have metastatic disease they should go for molecular alteration to check for rare mutations because they get benefit in improving overall survival and progression-free survival. Thank you.
شكرا دكتورة خلود. بنقدر ناخذ كم من سؤال إذا حدا من الأودينس بحب يسأل. بعرفش الدكتور وليد بعده معانا ولا غادر؟ دكتور وليد الزعبي موجود؟ وينه؟ مش شايفه أنا. خلاص that's okay. Okay. So we can go for a 10 minutes break. تفضل.
تكريم انهم يدرون انك تقدمهم انت
هلا؟ طيب اوكي.
Well, thank you. Thanks again for Dr. Ghadir and Dr. Khulud for the nice presentation. You know, seeing this nice presentation, it just confirmed the our feeling and our Dr. Well yesterday talked about the real need for a good oncology center here in Palestine. You know, we have Augusta Victoria. I think it needs more support and more more governmental support. We need a good oncological center here in Hebron as well. You know, we don't have any. And it's not only for treating the patients. Also, it's a big research center. It's. I really feel that it's a real national demand for having such a center. And you know, having our colleagues from King Hussein, Markaz Hussein al-Saratan, will be very helpful in creating such a center. Thanks for your nice presentation.
Okay. We are inviting the speakers عشان نكرمهم خليهم مسكرهم فكر بدروع. إذا بتتفضلوا دكتورة غدير عابدين. هو بلاش يفتح معه، لو خليته مسكر كان خلاص. دكتورة غدير شكرا جزيلا. اوكي ثانك يو. بس انتبهي البوكس. اوكي. دكتورة خلود القاسم. اوكي. مين الاسم؟ اوكي. دكتور علي الدغمين. لا دكتورة منال التايه.
دكتورة منال تفضلي. دكتورة منال هي استشارية تخدير في مستشفى الأردن وصديقتي وزميلتي، نتشرف فيها.
سلم. أخيرا وليس آخرا دكتور وليد الزعبي. دكتور وليد. يلا. We can get a 10 minutes break, okay? Then we'll move early to the next session, please.